This is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm pleased today to be introducing Rebecca Etz, Dr. Rebecca Etz, who is co-director of the Larry A. Green Center and also Associate Professor in the Department of Family Medicine at Virginia Commonwealth University. Dr. Etz, the show is yours.
Awesome. Hi, everybody. It's great to be with you. Some of you I've actually met, a couple of you I haven't met in person, so I'm sure we'll be meeting each other in person sometime in the future. But I know all your names, which is kind of freaky. So I've got a PowerPoint here for you about the measure that we've created, and I'm going to talk to you a little bit about how we got there, what it is, and where we're going to next. I understand there's a chat part of your window for those who aren't driving. If you have any questions, you should feel free. Sometimes it's hard to break in when there's someone speaking on a webinar, but you should feel free to go ahead and type something. I don't mind being interrupted, and I plan for lots of room for questions at the end. So unless anybody has any questions now, I figured I'd just start the show.
I have a question, Rebecca.
Yes.
I just dialed in on my phone. I didn't realize there was a screen. Am I supposed to dial in on my computer instead, or how do I get to see what you do?
Yeah, I sent everyone in the group a link just a few moments ago. If you want to go to your laptop and click on that link, you'll be able to see the PowerPoint.
Okay, great. Thank you.
You're welcome. You'll be able to stay on the phone too. You can get just the video through the computer as an option.
Perfect. Thanks.
You're welcome. Great. Okay. Well, I know one of the people not on the call is Kurt Stengy, my partner in crime. He'll be one of those people watching the webinar afterwards, but I want to thank him for going through this adventure with me. Lisa, if you'd advance. This is just to let you know, we've had a lot of people helping us out and funding from a variety of sources. I continue to be indebted to them, particularly the Board of Family Medicine Foundation, who funded our very first activity when nobody else really thought this would go anywhere. So I owe them a huge debt of gratitude. Next slide. I started this adventure, and I often start talking about it with this little story because it really hits on point, and it means I can blame everything on my mother. So when I was in college, my freshman year of college, my mother sent me an article from the Harvard Law Review along with a $5 bill, and the article said that rewards do not work to incentivize the behavior you desire. And my mother's note was that if I believed the article, I should send the money back. And I didn't, but I was planning to because she's quirky and so am I. And on my way to the mailroom, I passed by a Starbucks, so I bought myself a cup of coffee instead. And I like to tell this story because my mother believes she won because I kept the money. And she believes that she got the behavior she desired. And it just really didn't work out that way. And it is almost an allegory of how incentives and payment works right now with measures in primary care. And so this little story of dysfunction is always playing in the back of my mind when I start to investigate things. Next slide. The most important thing for me in anything that I do through the Green Center is that I have an investment in understanding the problem first and then finding the best possible solution for that problem. A lot of times in medicine, we start with knowing what we think is the problem and thinking about the constraints, and then we try to figure out what we can jerry-rig to work. When we do that, we allow somebody else to choose the parameters of the definition. We allow someone else to decide how the problem gets spelled out, and that forever predetermines what solutions we can come up with. I really, when questions are particularly intractable, is when we need to realize that the problem is probably not well defined. So we always go for the learning how to listen, learning how to ask, finding the best definition of the problem, and then the solution that would really be the best possible solution. Only after we do that do we start to think about applying constraints, so that when we make those eventual and necessary compromises, we are doing so from a position of knowing what it is that we must retain and what it is that we are able to negotiate. So people say, why do I care about measures? Why do they matter? Well, they always matter. Measures are really about self-definition. It's not simply an assessment. It is a statement of what you do, what you stand for, and of what value it is. When you are measured by something that is not aligned with how you self-define, it is dehumanizing, it's dismantling. It is actually a kind of a structural violence, and it is something that family medicine has for too long accepted. We have not generated primary care. We have not generated our own measures. We have allowed others to generate measures and have them applied to primary care. We've actually worked ourselves into a position in which the measures define how primary care is experienced by others and not how it experiences itself. There's no authorship there, and without authorship, you cannot have agency. So when you self-define and you create measures that are actually aligned with what you stand for, what your values are, measures do what they're supposed to do. They are supposed to help you to understand your potential and your aspirations. They are not intended as targets. There's a wonderful maxim, when a measure becomes a target, it ceases to be a measure, because measures are not intended to tell you where perfect is and how far from it you are. They are intended to help you to understand where is the world of possibility and where are the vectors where you can point your attention so that you can get the highest potential possible in those vectors of possibility. That's the kind of measure that I'm interested in creating and having family medicine and primary care follow. So there are very definitely ways of knowing about ourselves and how we communicate, and every telling is motivated. Every kind of communication has a purpose. In the case of measures, the purpose in the U.S. healthcare environment is to communicate value. And we can talk in the future about how we define value and how it gets used. But if we are using measures to communicate value, the measures applied to primary care right now fail to do that. So this was a problem that I was interested in trying to fix. Next slide. I thought about measures and data and people's EHRs as a triple threat to the triple aim. And earlier, Allie was actually looking at the slides and asked me about the quadruple aim. And the quadruple aim is very important. The triple aim is about better population health, better patient experience, and smarter spending. That's the latest sort of way that people talk about it. The quadruple aim adds in the idea that we must necessarily be concerned with the health and professionalism of the people working within primary care. And I actually fully support that. I just have a little bit of a quandary with how I talk about it, because I think everybody has the right to live in an ethical and non-hostile environment, and everybody has the right to work in an ethical and non-hostile environment. And it seems odd to me to single that out as a function of the healthcare system. I feel like it should actually be a given. So I was talking here about a triple threat to the triple aim. The first threat is actually about accountability. And I believe that accountability undermines value. What I mean by that is that accountability is a financial and business term. When it is applied to primary care, it is usually used as a way of determining if an individual physician has delivered on the goods. And what can we hold that individual physician accountable for? The problem is that somebody's health is far more dynamic than that. Medical care, we know, is only 20% of what affects and impacts people's health. It is ludicrous to hold any one individual accountable for the health of another, even a part of a person, if they are simply a diabetic. To hold one person accountable for the outcomes of an individual based on their struggles with diabetes is impossible. What it ends up doing is creating measures that people believe we can be held accountable for, unnecessarily limiting the scope of medical care. It unnecessarily creates a fissure between the ability of medical care to interact with social care, emotional care, behavioral health, all public health, all the other sectors with which we should be engaged. So it works instead of holding somebody to a standard, it works to limit their responsibility. And you see that a lot in practices now. They talk about accountability and they want to know what's their responsibility and what isn't, and they only want to be held accountable for that which they can be responsible for. Instead of believing they have a responsibility for the community in which they're located, used to be the way we talk. They now talk about an accountability for certain outcomes of their patient panel. It's an automatic and immediate narrowing of the scope of primary care that's done a great deal of damage to us that I'm hoping to correct. So that's the first threat to the triple aim. And in my little boxes there, related to that, there is a lack of agreement on measures and the modalities of measurement. There is a high administrative burden related to measurement, and those two aspects of accountability are the ways in which it plays out to do damage to primary care. The measures that we use fail to actually evaluate primary care in any meaningful way, and they fail to evaluate health. The third threat is a co-opting of health data with payment. So not only do we have a lack of access to our clinical data because we can't get into our EHRs and mine them the way we would like to, but because we have created the collection of health data as a payment-based activity, we've made our electronic medical records political documents. They no longer capture the health of the American public. What they capture is what it is that we're able to bill for, which is usually about how we stay financially viable and or how we maximize access of our patients who have unrealistic limitations on their insurance and therefore access to care. So the interaction of payment with measures that are based in clinical information has created a huge and unnecessary weakness in our ability to actually know the health of the American public and how we might address their issues. Next slide. So I talk about this as being a quality chasm, and yes, I do mean that tongue-in-cheek because of the Iowa Quality Chasm report. For me, the chasm is of a different sort. It is really between the business of medicine and the lived experience of the human condition. Medicine is a business. Health systems are designed around fiduciary responsibilities, and I understand that they need to be. They usually are designed around restricted business models that are based on that fiduciary responsibility and not actually on people's health or the needs of people who see us. And they have regulatory technology that contains what they can and cannot do with the information they found. So what we need to do is do a better job of creating the gap between the transactional side of medicine and the healing side of medicine. And that's what I mean, that we need to cross or bridge this chasm between the business of medicine and the lived experience of the human condition. Next slide. This right here is actually a famous building, but I use it often to represent primary care in the U.S. as we know it now. It has been built on precedent in incremental pieces, little tiny bits adapted and innovated. What we get in the end is recognizable as a building. It's recognizable that it has windows and a general structure, but it is certainly not the place I'd want to go to get care. Next slide. This is where I'd want to go to get care. And this is Falling Water by Frank Lloyd Wright. This is a building, think of it as primary care, that is born organically from its environment. It is intended to weave into the environment. It's actually literally intended to extend beyond its wall and to recognize that there is a boundary space between medical care and the rest of the professions that assist people in their quest for health and healing that is kind of fuzzy, and it's got some dynamics to it. And that boundary area is probably the area that we do the least well. In order to figure out how to address all these problems I've been talking about, I focused in on measures. How can we learn to listen to what it is that people find so disheartening about them? How can we learn to listen to the reasons that people seek care and the needs of those who provide it, and design the best possible solution to meet the problems they identify? Only after that, after finding the best possible solution, should we apply constraints. And then we have to let it loose in the wild, and we kind of kick the tires on it, and we make sure that it functions. It's sort of a second layer of constraints, but those are just technical ones. I don't design around the abilities of EHRs. We make the technology fit us. We can't have that as a limiting factor in our imagination or our innovation. Next slide. So we need to start over. These are the two quotes, the two thinkers that I often look to that I look to for this particular project when thinking about measures. The first is a well-known anthropologist who wrote a book called Writing Against Culture, and it's a way of reflecting. And when she was talking about the work she was doing, she said that in creating culture, we assumed a division between the knowledgeable scholar and the person under investigation, the other. And that primary creation of a division and a hierarchy that's created by that is the source of most of our problems when we talk about cultural exchange. The same could be said true for primary care. We assumed, as we created it, that there is a division between the physician and the patient. We break the primary magic of primary care when we do that. We break the connection. The physician and the patient are actually a single agent within primary care. It's part of what makes us so unique. After we reflect, we need to then innovate. And I love the warning that Gail Stevens gave us. When he was starting family medicine, he said that man has become a tool of his tools. He must once more become an end and in value in and of himself. We have forgotten the value of primary care. We think of it as a basket of services or a basket of tools. We in our measurement, in our policy, in all the ideas we put forward, we limit primary care to a set of transactions. We limit primary care to a set of codable, tangible outcomes, and it is so much more than that. It is relational and experiential at base. Any measures created to understand primary care, whether it is of good quality and whether people are receiving it, must be experiential and relational at base. Next slide. So the first thing we did was we decided to listen to people, and we did a crowdsourcing activity. We sent surveys that used very open language. How do you know good care, and how would you want to assess it? We asked people to type in answers. These were not structured. And we got about 500 clinicians, about 500 patients, and about 100 employers. And since they could give us multiple answers, altogether they gave us about 12,000 answers. And we used that to determine what they felt was most important about primary care. Once we thought we had it, we sent it back to them to member check to make sure. What you see in that blue rectangle on the side is absolutely absurd. It's what you get when you take a qualitative researcher like me and ask her to put together a quantitative chart. This is a scatter graph. And what I did was along the bottom, it's a whole bunch of dots, right? And what I did is along the bottom are all the responses we received. And along the side, or the y-axis, are all the codes we used to understand what it was that people said. And we applied about 100 codes to the 12,000 responses that we received. The reason you see it white in the middle is that I grouped in the middle all the codes that related to measures currently used in primary care. And when you see this on a big poster, which is often how I present it, what you notice is this literal tunnel vision in the middle. The tunnel vision in the middle is the part of primary care, it's the part of people's answers that they said were, these are the things important to primary care that was actually covered by current measures. The stuff that you see in the blue is stuff that is not covered by current measures. And I use this when I go and talk to CMS or NQF or NCQA, and I say, you have started national efforts to reduce the number of measures that we have. Thank you. That will be a huge help. We have made way, way too many. However, based on our research, what we know is that you will get better and more efficient at what you can see in that tunnel. But without addressing the root causes of the problem, you still fail to see nearly 60% of what it is that is most important about primary care. Instead, you focus only on this tunnel that is about prevention, surveillance, disease pathways, and the use of non-primary care services as a way for understanding whether primary care is good. It's just not sufficient. Next slide, please. We then took what was in the 60% as well as what was in the 40%, and we did a coding that allowed us to develop 18 areas or 19 areas that were of interest in terms of quality from the ground up of what people said. We took these 19 areas and we held a conference in DC. So first we were learning to listen. Now we were at the point where we needed to design around what people told us. So we invited 70 international and national leaders in primary care. It's up on our website at the Green Center if you want to go see it. We had a huge variety. We had internal medicine, family medicine, primary care, behavioral health, occupational therapy, social work, nursing, pediatrics, pharmacy. We had actuaries, we had patients, we had patient advocacy groups, we had foundations, we had CMOs of a tremendous variety of individuals. And I invited them for the 2.5 days. And when they got there, I opened up the meeting by saying, this is going to be work. There are no talking heads. We're going to use the information people gave us and go through a series of exercises. You all have been invited here because of your positions and your knowledge and your ability to make decisions. But your position, you can do what's right. I ask you to leave your day jobs at the door. Don't worry about those constraints. Let's figure out what we all know to be right. Let me work on it, and then we can apply the constraints later. And they actually all bought into it, which was incredible. And by the end of the conference, all those people actually agreed. They agreed on 11 items. They got rid of 8 of them. They were either redundant or didn't seem necessary. We audio recorded everything that people talked about. And we had as our goals to advance the findings that we learned from our survey and to develop a single voice that was influenced by the multiple sectors we were interested in. Next slide. We left Starfield 3 with an understanding that primary care continues to hold 2 competing ways of knowing the world in one coherent whole. This really is something that's unique to primary care. And there's a strange thing in primary care where people are always worried about what's unique to it. And it's a weakness, because when we think about some things that are important for all medical care, sometimes they don't want to own it because they say, well, that's not unique to us. Other people do that too. I think it's okay that there are standards that cross disciplines in medicine. But the thing that really is unique about primary care is that it holds, as Gail Stevens said, on equal footing, the world of the social along with the world of the scientific. That's in fact why it is that we talk about whole person care. We know that disease is biological, but illness is a human condition. And how we think and feel is as important and influential to understanding how health is won and lost as anything else. Primary care does that well, even though we have not written that up well. That's one of my next projects. But the conference made it very clear that primary care has all these broad elements invested in it, that they are interdependent. You cannot look at them separately. You must look at them as a whole, and they require an integrated assessment. So that's what we set out to do. Next slide. A lot of times people say, well, what does that look like? And so I offer this as a little example. This is probably the one time where it's a shame we don't have animation, because those three little dudes on the conveyor belt in the bottom corner are just kind of sloughing along in their job. And it's sort of an example of what I think many docs feel. When we talk about population health, which for me is something very real and tangible, the way we address it through measures in primary care is by rates of, percents of, and something was offered. So you get these strange conversations. I've sat in rooms with doctors I actually admire, where they say, where they're told about the need to make sure people get vaccinated against, say people get Pneumovax or get a flu shot. And they say, well, if I offered it, but they refused it, do I get credit for it? And I understand the impulse. I know why they do that. But at the same time, if we're thinking about population health, well, no, you don't get credit for it. We've still got a problem of potential spread of disease in our population that we need to address. A strange sort of curtailing of that sense of responsibility. When we're in medicine, how do we actually talk about population health? We talk about the need for information management. We talk about the need to have data that we can use to make clinical decisions and to know and find gaps in care. We talk about the experience of people and of their healing. We talk about social factors influencing their health. We talk about the need to maintain a large population view even while we provide personalized care, and to do so in a proactive way. And rates of, percents of, and whether or not something was offered seriously fails to capture those things that we find important about population health. Next slide. So we took what we learned from Starfield and we said, okay, how can we make this feasible? We created a single measure of 11 patient-reported items. We wanted one item for every one quality area that was felt to be part of a whole that we call primary care. You'll notice when we get to it that there are no intermediate clinical outcomes in our measure. I do not believe intermediate clinical outcomes are a good indicator of the quality of primary care. They are absolutely necessary for clinical decision-making. They're absolutely necessary for understanding population health. They are critical to learning about the guidelines that we need to know whether somebody's doing well or not. But somebody's intermediate clinical outcome at a specific point in time does not necessarily correlate to quality of care or to how their health is going to go. When I stand in a room of oncologists, I say, imagine capturing the point at which your patient is on their 8th round of chemo and saying that their outcomes at that point is an indication of your quality and of their eventual health. We would never dream of such a thing. nor will you see in this measure things that are about process or proof of delivery. We do not know the quality of primary care by proof of delivery. Again, I understand that's a conversation we need to have because insurers, as the people paying for care but not present for the delivery or the receipt, need to have some sense that something happened so that they know that they're paying for something. But this is not how we determine quality in primary care. So we identified 11 quality areas through the crowdsourcing and listening, and then designing with knowledge of the system in mind using those 70 experts in the room, including patients. And we created one item per quality area. We then sent it out online to 1,000 people to test it. We sent it to a second group of 1,000 people to see if we could replicate it and determine the measure's reliability. And then we did a third round where we tested it among patients at point of care. We did it in an all pediatric environment. We did it at a community health center, at a private practice, and at a hospital-owned primary care clinic. Through all of those rounds, statistically, the differences were negligible. The performance of the measure remained the same throughout. Next slide. So usually, I don't have you see the table before I describe to you what the table's going to say. And that's because I find many people don't know what factor analysis is or how to understand it. And in truth, I have a psychometrician who works with us. He's at the top of his game, and I trust him. I don't know how to do the math. But if you look in the upper right-hand corner, you'll see I've got something that looks like a speed dial. When you do factor analysis, you end up with a number that is somewhere between 0 and 1. And based on the number, you know whether the question you've asked is a good or not a good question, able to assess the thing of interest to you. If in the factor analysis, the value assigned is at least a 0.4, that's the goal, then you know that your question is a good question to use to assess the concept that you want to understand. If you have a value of 0.6, it is a very strong correlation. If you have a value of 0.8, I put that in blue because it is an unusually strong correlation. People usually are looking for that magic 0.4. You've heard of p-values and 0.05. 0.4 is what we're going for. What we found when we did the factor analysis on this is not only were all of these questions significant, they were unusually so. They were very strongly aligned, and they were strongly aligned with a single factor. This does not divide up into individual domains. There are no sub-themes. It is 11 items that work together statistically to inform a whole. And this was really kind of fascinating because we used qualitative methods up to this point, and then when we applied the math to it, we found that it supported the very thing that we say. Primary care is broad in scope and internally coherent. It is comprehensive and yet personalized. The item total column lets you know whether or not the questions stand on their own and whether or not there's any redundancy. What we find, again, seeing the strength of those numbers, that we don't in fact have redundancy. So each one of these questions is a necessary part of the whole. Next slide. This slide is unnecessarily busy because I find that people want to know the information, but they don't really want to know the information. So I do this one kind of quickly. On the bottom left, you see the range of scores that are possible. They go from, since we have 11 questions, and you can answer the questions definitely, mostly, somewhat, or not at all, with definitely being a 4 and not at all being a 1. It means the possible range of scores you can get go from 11 on the bad side to 44 on the good side. What you see here is a nice spread of scores. It's unusual. You usually don't see that kind of flat spread. It means that our entire scale is being used. If you've ever looked at patient satisfaction surveys, you know that it often looks like an asymptote, where it is very low and skinny for most of it, and then on the far end, in the positive side, it's very high, because people just kind of circle all fives and move on. For whatever reason, which we have studies going on now to try to understand better, people don't do that with this particular measure. What you see on the right-hand side of the screen is rash modeling. It's a third kind of statistical analysis we did to make sure we had a good thing going here. I can, in the Q&A, I can explain it to anybody who's interested, but what's most important here is to see the spread of people's responses on the left, the fact that the questions are spread out and not overlapping on the right, and that they are all within this range of 5 to -5, which means that these are, you have a healthy distribution of hard and easy questions and no redundancy. Next slide. As we fielded it and determined its validity, that we then wanted to know, so what kind of impact would this have anyway? So when we fielded the measure, we did so alongside 2 already validated instruments. Now, I'm going to speed up here a little bit because I'm just taking note of the time. So we have the Patient Enablement Index, which is a 6-question instrument that talks about patients' ability to self-manage and cope or understand their illness. When we fielded our measure alongside the Patient Enablement Index, we found a very strong correlation. That means if you do well with this measure, you are more likely to be a patient that is able to self-manage and feels able to understand and cope with their illness. The same is true for the What Matters Index. The What Matters Index, created by John Watson's group, you guys have probably heard of, is validated to both retrospectively and proactively speak to cost and utilization. So you notice that both online and in person, we strongly align with the What Matters Index. In person, the p-value is 0.08, not 0.05, which means that it's not quite as strong as we would like, and we can't say it's a direct correlation. It's just close. And that's why one of the first follow-up studies we're doing is to collect cost and utilization data correctly alongside our measure. We did ask the question, and I really love this, if your doctor had the answers to this survey, would it help them with your care? And we got an overwhelming response of yes to that. We asked if the survey was hard to complete, and we got an overwhelming number of people who said no. Out of the 22,027 online responses, we had 17 people who found it difficult to answer. There was very little change with the performance of the measure in terms of age, in terms of income, male, female, minorities, status, whether they were using their smartphone or desktop computer, and where they were located in the country. This turned out so far to be a very robust measure. Next slide, please. I put this in there because I am not trying to kick people who have come before us. So the measures that we have, they were the best thing we had at the time, and they're good. We actually really need as many measures as we can possibly get for clinical decision making. They are not useful for assessing primary care performance, and that's the distinction that we need to make clear. Next slide. So where are we going to next? We are in the process of validating this measure in 28 languages in 36 OECD countries. We actually have finished our data collection, and it's sitting with our psychometrician right now for analysis. We have some US-based clinical trials going on thanks to people who are willing to experiment and volunteer their time. So we have a system that will be able to collect cost and utilization data. Not sure how long it's going to take us to do that. We're setting up with that system and with Anthem now, so I can let you, I can continually update you guys. We are also fielding it with PRIME, which is the ABFM Quality Measures Registry. We're fielding it alongside usual traditional measures there, along with 3 high-value primary care measures that Bob Phillips and the Graham Center have created around continuity, comprehensiveness, and low-value care with the help of the Stanford team. So we'll be able to compare it against those there. And then we have a couple of groups in Canada, one in Toronto and one in Ottawa, that are doing some initial quality improvement programs to see how the measure performs against those. I'm also aware of groups in China and Japan that are fielding this measure. Right now, they have just finished the cognitive interviewing with their patients, and they are getting their IRB and paperwork ready so that they can start to implement. So we don't yet know exactly what those trials are going to look like. We are testing it in 9 primary care settings to make sure that what we've isolated is in fact primary care and not just medical care in general. Right now, that means we are testing it in an emergency department. And we are in the process of applying for both CMS and NQF endorsement. We've been talking to both of those organizations. The CMS endorsement goes in September and NQF the following April. Next slide. I got all my funders here and just want to thank them again. That's all I got, and I'm happy to entertain any questions of anybody.
Rebecca, we have about 15 minutes before the recording cuts off, so good chance for discussion here.
Great.
Anyone have
looking for questions?
Yes,
Larry?
anyone have a question or a comment?
Yeah, this is Wayne Jonas. Thank you, Rebecca, for that great presentation. What a massive amount of work that you've done on a wide variety of folks. It's rare that a measure like this comes out with such favorable numbers. Yeah, in this, most of them are much more marginal, which is what you talked about. And, these are things, if I look at those questions myself and having gone through some medical issues myself, I think, golly, yeah, I'd like my primary care I'd like my doctor to do some of that stuff. So they got a lot of face validity too, which I really like a lot. And in those areas, I guess the question I have is, what is this going to replace? Okay. I mean, there's lots of measures out there. I'm going through a whole bunch right now to try to determine, well, what are some core measures from primary care that are representative of the quadruple aim, the triple aim plus, do we like it? Do we like practicing medicine anymore? And there's all kinds of measures out there. And what you just told me is that, well, that's all great for measuring systems, but they're very limited, they're very narrow, they're very focused. They don't necessarily help me to bring joy back into my practice so that I get excitement when I engage with my patients, which if I could answer yes to most of these questions, I'd have. So what is this going to replace? Is there something you're going to take out and put this in when it comes to primary care?
Yeah, so it's a great question, Wayne. I get it a lot, and I wish that I had the best soundbite ever for that. I don't have the best soundbite ever. I'm working on it, because what I would say is the measures we currently have for primary care are non-existent. The measures that we use are measures that are specific to understanding professional conduct, ethical conduct, and clinical decision-making. They don't tell us about quality of care. I would say that we need all of those measures. We should pay attention to them, but I don't think that they assess quality of care, we became, I would say, so fascinated by our ability to capture data that we forgot, we didn't go about creating medical records and EHRs so that we could become the best documenters of blood pressure ever. The purpose was to prevent stroke. And those things are necessary. Those clinical measures that you know are necessary for us to understand the health of the person in front of us. They are necessary for us to use the best evidence-based medicine possible and apply it to the particulars of the person in front of us. But primary care is not about how well you measure blood pressure. It's about whether or not the person in front of you is receiving access, continuity, comprehensiveness, coordination, full person care. It's whether it takes into, your care is taking into account your family, your health goals, your community, the social factors influencing health, your health, your whole biography that you bring with you, and all that that implies. What I think you're asking is, what would this look like down the line? And I think down the line, it would mean measure this, call this quality, and if you want to create a payment system based on quality, this is what you pay for. Those other things should happen, but they are not the basis of payment. They are simply part of care delivery. The analogy would be in architecture. We don't pay an architect for the number of pages in their blueprints or how straight we determine their lines are, or how many pages they faxed on a given day. That's just simply, creating a blueprint is simply part of doing business. We consider quality in architecture to be the design itself, to be whether the building fills a cultural, emotional, and functional purpose. We sort of lost sight of that in medicine. So I think if you pay for this and take the clinical measures out of it, leave them in the world of professionalism and decision-making, then you also, in this encounter, take the insurance companies out of the room. So you begin to allow that encounter between a patient and a provider not to have these invisible individuals interfering it, that rupture of relationship starts to get restored. The conversation is directed about the needs of the people in the room rather than the needs of those outside of the room. And the collection of health data becomes an actual reflection of somebody's health and not something that's jerry-rigged to meet the demands of some other system. I think that's where we're going.
Well, I'm glad you brought the $5 back into it and said we should pay for this, because I think that's key. I just got off a webinar where they were explaining the new CMS model of primary care first, which everybody's hailing as, a revolution in value-based care. And as I was looking at the metrics they're going about, it's like sickening almost. It's variation on MIPS, and they're competing. They're putting one primary care group up against another. They will pay you if you're better than, what the average is, instead of incentivizing everybody for excellent quality. And it's exactly the kind of measures. It's the exact kind of measures you pointed out are at the middle of the tunnel. And it was so far from what you've presented here that I'm like, I see this huge gap on trying to help, close that in some way. Anyway. Thank you.
And it is huge, but Wayne, it's totally possible. So I can tell you, for instance, that CMS right now in their MIPS program, they are putting a tremendous amount of value and weight into what it is that the Core Quality Measures Collaborative says they should do. Mm-hmm. And that Measures Collaborative wants to adopt this measure.
Well, good. I'm glad
we have
to hear
to have
that.
it endorsed for them to do that. But they are ready.
Got it.
They've already had discussions to do that.
Good.
NQS,
So, Rebecca,
CMS, NCQA, they're already talking about it. Yeah.
Rebecca, there's just 5 minutes left.
Yes. Thank you, Larry.
Rebecca, this is Pat Tokars. I wonder if, similar to your discussions with CMS, tell us what has come about with Anthem and their coordinating your measures with their cost and utilization data.
Sure. So we are just starting that conversation, Pat, but we are working with University of Colorado Health System. They have 40,000 people insured through Anthem and 80,000 people for whom they have cost and utilization data. And they are talking to they've already talked to the state level Anthem person and now have to talk to the national level Anthem person to get permission to actually pay practices based on this measure. It's 40,000 is a relatively small group. We will be able to field it there anyway and look at the cost and utilization over time. Within a year or two, we should be able to have enough data to speak to that. But we are also talking to them about the potential to pay people for it. This measure is also being adopted by Prime. And because Prime is a QCDR, when we apply for provisional endorsement in September, a QCDR means that the people that are within Prime can get paid within MIP for their performance on this measure as well. So it's just starting, but we should have good and live data on that pretty soon. I might add that usually it takes about 12 to 15 years for a measure to go from conceptualization to being live and in use in a payment system. And we've only been at this for about 18 months, but we've been kind of fast and furious on it.
Have you been talking with any accountable care organizations?
Yes, we have been talking to 2 accountable care organizations, one in Cleveland and one in Virginia. That's not a coincidence. That's where Kurt and I live. And we're hoping to talk to others as well. I am totally indebted to my funders that you see here on the slide, but we have actually received very little funding for this project so far, and most of it has been done out of discretionary funds. So we rely on the fielding of this, really on the kindness of people willing to participate. It just so happens that primary care is in such a dire position that we are finding people who are willing to participate.
Wayne, I'm wondering if you have any thoughts about the VA and the Department of Defense in terms of this measure.
Yeah, well, I was thinking about that actually. I got off another call today in which they were describing a large, they got a lot of ability to collect large amount of data at the VA. And they have, major, efforts to advance primary care as a core delivery system within the VA, and through PACS and things like that. So I have been thinking about it. I haven't come up with anything brilliant except that the measures that are in here are getting back at a new model that the VA is trying to roll out, which is about whole person health care, and it's actually in some interesting ways it's bypassing medical care. It's being built sort of around the health delivery system with health coaches and allied health care and social workers and various other folks rather than in the center of the provider. So this could serve as a way of sort of anchoring the provider into that system, but I have to think about it a little more.
That'd be great.
This is Larry. I'm going to bring things to closure. Thank you, Dr. Rebecca Etz. This is awesome. And also, the group doesn't know this, but Becca, which is how she likes to be called by her friends, as she always says, she really bent over backwards to pull this talk together in a short amount of time so that we could be here this quickly. She's also going to be a plenary speaker at our annual meeting in Lancaster on Saturday. You'll be the core keynote presentation of our meeting. And by that time, I think there will be even more excitement to share. But Dr. Etz, thank you very much.
You are very welcome. Thank you, everybody, and please have a low threshold for reaching out with any questions.
So,
Rebecca,
Rebecca,
could
do
you
you want to mention your email address to people so they can reach you?
Sure, it's rebecca.etz at vcuhealth.org. It's Virginia Commonwealth University, vcuhealth.org. And since Larry
Great.
sent out the invite, it'll be on there. So if you reply all, it's somewhere in there.
Yep.
And we
Great.
can get more information from which website, Becca?
Green-center.org. If you type Larry Green Center into Google, it should come up as the first hit now.
Thank you.
You are very welcome.
So thank you all very much.
Thank you, Larry.
Thank you,
Thank you, Larry.
everyone.
Thank you, Rebecca. Bye-bye.
Sure. Bye-bye. Bye.
Bye.
So Lisa, you can stop the recording.